hospitals. You kind of get blackballed. By the same token, by the way, if you're a very good nurse, then when one supervisor moves from, let's say, Truro to Ochsner, when she's hiring nurses, she's going to try to bring you over to Ochsner. In fact, they'll give you a bonus to transfer if you're good. Everybody wants good nurses. You're worth your weight in gold. If you're not a good nurse, nobody wants you. And the problem is something that you can probably recognize right now, here and now in school, is that we have a lot of nursing students because we need nurses. There's really a shortage of nurses. But if you look at the nursing students from which they draw, some students want to learn. Okay, they want to be the best they can be. Other people just want to get by. C equals RN is the term they use. Have y'all heard that?
Yes.
Okay, so because they know that to pass the NCLEX, you don't really need to know a lot. The top 90% pass. The bar is set so that it filters out only the bottom 10%. And those people who are taking the NCLEX are all comers. They're people who went to Delgado and are getting an associate's degree. They're taking it together with our students who have a bachelor's degree and a little bit more scientific background. So it's all comers. Most programs that offer a bachelor's degree have an NCLEX success rate that's between 95 and 100%. That's not uncommon. Now, we like to brag, we like to we have 100% pass rate on the NCLEX, but that would also be true for a lot of schools. Okay? Not necessarily associate degree programs, but certainly bachelor degree programs. So, what you'll find as a result, though, is that the quality of nurses is very, very variable. And on the NCLEX, what you'll find is the questions are more like this. Let's suppose you're caring for a patient, and the patient's being discharged, and they demand to see the physician. But the physician is busy talking to another family at the time the patient's being discharged. How do you handle the situation? Well, it's more about interpersonal skills and what do you do in these situations, but it's not like the MCAT where they're going to ask you scientific knowledge. So yeah, you can get a C, and you can certainly become an RN. Okay? The filtering out process is more related to the academic curriculum, nursing school, than it is the NCLEX. The NCLEX isn't going to filter out many people. Okay? As long as you can pass through nursing school, you can make it, and many of those students do simply strive to get a C. So what you'll notice is when you go into the hospital environment, there's real variability amongst nurses. In fact, when I started working here, okay, I was shocked. Like for instance, I had no clue. I was shocked how little was required. And then it all made sense. Okay, why do we have such poor nurses? We're not requiring much of them. We're encouraging them just to get a C. Okay, and you'll make it through. That's all you need to do. I've heard Dr. Practice say to students, you don't really need chemistry. You're not a chemistry major. So our students, even though they've taken chemistry, don't even know what an acid is. In pharmacology, when I get them, I'll say, what's an acid? No clue. Okay? But if you want to be good, if you want to be promoted, if you want to be the best you can be, then you have to strive for more. If you want to be that good nurse, you got to do more, okay, than just get a C. You have to know stuff. Knowledge is power. If you know things, you're going to separate yourself from everyone else. And so when an opportunity comes to move up, whether it's moving to the ICU, moving to the ER, become a supervisor, you're the one that they're going to pick. Everybody recognizes talent. Everybody does. Everybody knows who the smart nurse is. You don't want to be that nurse that doesn't know where to palpate for the posterior tibial pulse. Okay? That's kind of embarrassing when those things happen. And they happen. They happen. Okay. What I want to do now is have a volunteer. In fact, two volunteers. On take the pulse. Okay?
Okay, go ahead.
Chris, what I need you to do is come over here. And I just want you to chill. I just want you to lie down on your back. If you don't mind, go ahead and take off your shoes. Just relax.
Just relax.
Now, onto this is for you. Every good nurse carries KY. Okay? Yeah. It's KY jelly. KY jelly. You never know when in a pinch you need a little KY. Okay? So what we're going to do is take off Chris's socks. Okay? We're going to check pedal pulses. You might want to pull it up a little bit. But you're in good hands. So you're going to put it over the point where you're going to listen for the pulse, because the Doppler is going to allow you to hear flow that you otherwise would not hear. Now look here, this is important. You see this first tendon here to the big toe? You don't come up here. The dorsalis pedis pulse. The dorsalis pedis pulse is going to tend to be between this first and second tendon here. So if I put my fingers in here, I'll tend to feel it somewhere in this region here. And you always palpate with the first two fingers. Now, this is the medial malleolus. I'm going to palpate posterior to it. Sometimes the pulse is a little bit deep. Sometimes, because it's so distal, it might be a little weak. If you don't palpate it, you can use the Doppler probe to hear it, as long as there's blood flow. So you're going to put some KY over the dorsalis pedis, and that's going to improve the connection here between the probe and the vessel. So now you're going to turn on the probe, and you're going to go ahead and try to position so that you can hear the pulse. You want to put it 90 degrees to the vessel. Would be more like this.
Yeah, I don't know.
Okay. All right, so you're going to do it, not me. So you're going to now choke up on the bat. Choke up. That's it. Okay, and then all right, move it a little more proximal. Stop. All right. So do you hear a pulse? You do?
It's like really tiny.
It's very faint.
Yeah.
Try to see if you can make it a little louder. See if you can move it around to find the ideal spot. Move it a little bit that way, to the right or left.
Go up more.
Come distally. Come distally still. So this is sometimes what you'll be doing to try to find a pulse. Let's see.
Your foot is dead.
Shy.
Bring his toes back up a little bit. Dorsiflex him a little bit.
Oh, there it is.
There we go.
All right, so that's dorsalis pedis. So it requires a little bit of manipulation. Now let's try posterior tibial. Okay, one.
Alright. So you want us to put it
Reassurance first.
right. Are you okay?
You're gonna feel a little cold sensation.
You're gonna feel a cold sensation.
Okay.
So put it right here.
Well, it's gonna be just
More
posterior to the medial malleolus.
When I did my PA shadow, I removed stitches from someone, staples from someone's belly, and he told me to warn people about my cold hands.
Mm. There we go.
That
That's
was
an
good.
expert job right there. Now,
Whoa.
turn this up. Now we're going to have Chris lie prone. So you can ask him to lie prone.
Please like prone.
Now, he's not going to know what that means. He's a patient. So what are you going to say?
Sit down. No, sit up. I don't know.
On my stomach. On my stomach.
Yeah.
There you
on your
go.
stomach.
There you go. Lie down on your stomach. Now, if he could lie with his head the same way it was before. All right, what do you think you're going to do now?
Dorsal.
No, popliteal.
Popliteal.
So go ahead, let's see what you would do to check the popliteal. Well, that's the best way.
Okay.
You're not going to Doppler over the knees.
I'm gonna roll up your pants.
This is a great view of your butt, Chris.
I don't know if it's gonna go.
You need to be a little more aggressive. Come on.
It's okay, Hunter. Chris is used to women touching him.
Okay. Now, I can palpate his popliteal, but it's gonna be somewhere right around here. Okay? All right, now,
Put on the jelly.
okay, again, remember you're talking to the patient.
You're about to feel a cold sensation.
You want to, minimize the laughing, by the way, when you do that.
Okay.
It doesn't instill confidence when you're disrobed and the patient's laughing. The patient, the nurse is laughing. You're right around, I can hear it.
I'm on the X.
There it is.
So many times, that's fine. And then what you want to do is then clean the patient up when it's all said and done.
Go get some paper towels.
The idea is that many times you'll be asked to check pulses, and if you can't palpate, sometimes it's tough to palpate, you can pull out the Doppler probe. You want to make sure that there's still good flow.
And every hospital should have one of these?
Oh, yeah.
Okay,
Yeah, there'll be a Doppler probe on every nursing floor.
okay.
It's early in the ICU setting.
Alright.
Can nurses carry their own?
No.
Okay.
Most nurses do carry around some KY. They just do. Because you can use KY for, it's more than just for doing
Right.
this. If you want to do
Rectal
a
exam?
rectal exam, you'd want to be gentle.
Just saying.
That'll be further down in the semester. Still on cardiac right now. Okay. So, very good.
Now you know what it's like to be a pregnant woman. I don't like how you can't see where it's,
Yeah, I know.
what it's going. I'm like, oh, I'm not the right spot.
Yeah.
I might just want to cut that part out. I made a lot of inappropriate comments.
What's the name? Just something to talk about.
inappropriate.
Right.
Just have to do some things that you're not comfortable with.
I may be better if I don't know the person.
Okay. Learning the veins, once you learn the arteries, learning the veins is a little bit easier. The only major difference is that along the extremities, there are two groups of veins. You have the deep veins, which correspond to the arteries, and then you have a set of superficial veins for which there are no corresponding arteries. But the deep veins generally, not always, but generally carry the same name as the nearby artery. So what I'm going to show you here is that just medial to the femoral artery is the femoral vein. Okay? When the femoral artery bifurcates into a superficial femoral artery and a deep femoral artery, then the femoral vein bifurcates into a superficial femoral vein and a deep femoral vein. Okay? So just as you have a dorsalis pedis artery and a posterior tibial artery, you have corresponding veins. These are all deep veins. Now, here's what happens. When the common femoral vein crosses the inguinal ligament on either side, what's the name of the vein now? What does it become?
External.
External iliac vein. So this would be the left external iliac vein. Now, when it's joined by the internal iliac vein, when they anastomose, this is now the left common iliac vein. Okay? And the right and left common iliac vein join together. There's no aortic vein. This becomes the inferior vena cava. Right? Now I want to point out something that within the abdominal cavity, and this is within the abdominal cavity, the inferior vena cava sits to the